Hello, I'm Richard Westerby from IV Fertility Services, and today we have Lauren Garrett from Pacific Northwest Fertility, who is a genetics counselor, and she's going to talk to us all about genetics. Lauren, hello.
Hi, Richard. Thanks so much for having me here today.
Oh, you're very welcome. So today, genetics. What I'd love to talk to you about are different stages of fertility treatment and what are some of the things that we can do to maximize success and what are the different types of testing that can be done. So say, for example, before I start the process and I
Mhm.
think of making a family, what can I do to maximize my success from a genetics perspective?
Yeah, sure. So genetics is certainly becoming a part of many different parts of a patient's fertility treatment. When we're talking about testing options that can be done before treatment starts, we tend to refer to this as preconception genetic testing. And probably one of the more common types of preconception genetic testing in the fertility clinic is something called expanded carrier screening. And what expanded carrier screening does is tend to look at a panel of genetic diseases. They tend to be recessive, autosomal recessive diseases, and also X-linked diseases. And typically for any pregnancy or any embryo, we are going to want to look at the genetics or an expanded carrier screening panel of the egg and sperm provider for that pregnancy.
So what does recessive and what does X-linked mean?
Sure. So these are two different types of what we call inheritance patterns in genetics. So an autosomal recessive disease is going to be the type of disease that's going to be at risk when sperm provider and egg provider for a pregnancy both carry for the same disease. So in other words, both have to be a carrier for the same disease in order for there to be a risk for the baby.
So I carry disease X and my egg donor also carries disease X. That means that my child will have that disease.
That means there's going to be a 25% chance for that child to have that disease.
Okay. And why is it 25% chance?
Because for each copy of the gene we have two copies of each gene, one from our mother and one from our father. And so in order for an individual to be affected with disease, they have to inherit an affected copy from each side.
Okay. So that means that there's a 25% chance that I have that inherited from both of them. What about the other 75%?
When you have a mother and a father who both carry for the same disease, there's going to be a 25% chance to have an affected child, 25% chance to have an unaffected child, so no mutation, and a 50% chance to have a child with a carrier status just like you.
So there is still a chance that they have it and you don't, which is great. So so this expanded carrier testing, how do you do that?
Typically, there's many labs that offer what we call the expanded carrier screening test. It can really vary which panel your clinic is using. There's different labs that offer this test. They tend to be different panel sizes. Most of these large panels will include one of the most common diseases that we see in the population, such as cystic fibrosis, SMA, Fragile X, alpha thalassemia, beta thalassemia. Oftentimes they include additional diseases as well.
Is it a blood test? How do they do the actual test?
Typically, you can either add this onto a blood test if you're doing other screening tests at your clinic, or sometimes the lab or even maybe the clinic can actually send a saliva kit to your house.
Okay, so it's not like cutting some hair and sending that.
No.
No. And is it the same as 23andMe?
It's the same and different. 23andMe also is what we like to call a recreational test. So it's not really designed to be for use in medical clinics or in fertility treatment. However, some of the diseases that are on 23andMe may also be picked up on a carrier screening test. There can be some overlap.
Okay.
And so if you know you're a carrier on a 23andMe test, such as cystic fibrosis, there's a good chance that the expanded carrier screening test will also
Pick it up.
Yeah.
So if you've done me, do you still need to do the expanded carrier test?
I always have my patients do that.
And then what is an X-linked?
So an X-linked disease is just a type of disease that happens when there's a mutation traveling on the X chromosome.
Okay.
Okay. And so there can be some different penetrances of X-linked disease. Typically, males, since males have one X chromosome and one Y chromosome, males tend to be more affected, meaning if there's a mutation on their X chromosome, there's a higher risk of showing symptoms of disease.
Because a female is XX and a male is XY.
That's exactly right.
Okay.
You got it.
So, yeah, okay. So then is an X-linked disease on both of the X's, therefore it always travels down, or is it only on one of them? Or does it depend?
Typically with X-linked dominant, you just need one mutation on the X chromosome in order for there to be disease. X-linked recessive tends to be on both X.
So this is testing that can be done before even thinking about conception, right? You can do this and understand your status today, so to speak.
Yeah, and really the utility of this test in the fertility clinic is really to identify sperm and egg providers who are going to be carriers for the same disease so that we can offer something called PGTM, and we'll get into that a little later as part of their treatment plan.
Okay, because that's exactly where I was just about to go.
Convenient.
Surprise, like great segue in. So we've done the testing and they do the same testing and they come up with the same recessive mutation as me. What then?
Somewhat common. So we actually say about 4% of couples or matches will be carriers for the same disease. So pre-implantation genetic testing for monogenetic disease, this kind of puts us into the next category, which you want to talk about.
Okay.
Yeah.
So what are the tests available? And on an embryo, what do they do?
In general, that's kind of a category of testing that's specific for testing an embryo, right? Testing, basically biopsying that embryo and testing the cells of the biopsy and getting a result before the embryo is implanted for pregnancy.
Brings me in my mind to two things. One, you're testing an embryo. So how do you test the embryo? And two, when you're testing it, does it damage the embryo?
So how you test an embryo is simply with a biopsy from the outer layer of the embryo known as trophectoderm. Okay. And so they actually can take about 5 to 10 cells. The embryos typically stay cryopreserved at your clinic. The cells themselves actually get shipped off to the lab for whatever testing you're having done.
And then does it damage the embryo?
No. So there's been lots of studies kind of looking at whether or not the biopsy damages the embryo. You're going to want to limit the amount of biopsy to the embryo if possible, but typically one biopsy isn't expected to damage the embryo. And remember, we're really just taking a small amount of cells from that outer layer of the embryo.
And then testing those cells to see if there's any defect.
That's right. Performing whatever type of PGT testing is being done.
Okay. So in my mind, you have a football of cells.
Mm-hmm.
So you are going to biopsy some of those cells from the football. What if you're biopsying a part of the football that is a bad part and the rest of the embryo is a good part?
I think you're getting into a category of testing called pre-implantation genetic testing for aneuploidy, known as PGTA. And what PGTA does is it screens for aneuploidy. And aneuploidy is a term that means extra or missing chromosomes. Okay. And we know that 50% of first trimester miscarriages are caused by chromosome abnormality, right? So the utility of PGTA in a fertility clinic is really to select and identify the embryo with normal chromosomes. We can have the best chances for healthy life birth and lowest chances for miscarriage. And you talk about this football. I think what you mean is there is a type of PGTA result called mosaic embryo. And what a mosaic embryo result means is that when they took the cells of biopsy, they saw a combination of cells with normal chromosome amount and abnormal chromosome amount, kind of like a hybrid.
Right.
Yeah.
So then if you have, so PGTA for aneuploidy, where the number of chromosomes is correct, you see 46.
We call that a euploid result.
That's a euploid result. So a euploid embryo is the correct number of chromosomes within the cells of that.
Correct. We want to see 46, 23 from the sperm, 23 from the egg.
And can you see if they're male or female?
So the X and Y result will tell us whether it's XX female or XY male.
Because in some countries, you're not allowed to see that result, right? But in the United States,
not in the United States.
The US, you're allowed to see that
we're
result.
allowed to here.
Which then leads to the question of you can select the sex of the embryo that you are then going to want to use.
That's right. Mm-hmm.
Okay.
Yeah.
Going back to the mosaic embryo, what is the difference in mosaics? Like how does that work?
But in general, what they have found with mosaic embryos is that you can have healthy live birth. You may have increased miscarriage rate. There may be a slightly increased risk for chromosome abnormalities. But in general, mosaic embryos, many clinics are now transferring them because they're another option to patients if needed.
So flipping back to what we were saying before. So I carry something the egg donor in my family, she carries something. We create an embryo, knowing that we both carry something. How do we then test if that embryo has that disease or not?
So that's a second type of pre-implantation genetic testing called PGTM. And in this case, the M stands for monogenetic disease. Okay, so let's say you are both carriers for cystic fibrosis. We know that this is a type of monogenetic disease, meaning we know that one gene can cause a disorder. And what PGTM is really a custom test that's designed specific to your genetics. It's usually outsourced to another lab. So typically most fertility clinics don't do this testing in-house. That lab is actually going to custom develop your PGTM test that's specific to your genetics. And really the purpose of that test is to find which embryos are affected with disease, which ones are unaffected, and which ones are carriers in the case of cystic fibrosis.
So coming back to that percentage-wise, the 25% that have, the 50 that carry, and then the 25% that don't.
That's right.
So PGTA, pre-implantation genetic testing for aneuploidy, is just counting the number of chromosomes. GTM is for a specific disease that I know that potentially the embryo can have.
Yeah.
What other PGTs are there?
Probably the third most routine PGT test that's currently being offered would be something called PGT-SR. And SR stands for structural rearrangement. And this is going to, while I think of PGTA as kind of like a routine screening test that anybody can do, PGTM and PGT-SR are going to be more indicated for certain patients, where PGTM is indicated for a couple with a high risk of genetic disease. PGT-SR is going to be indicated for a couple in which one partner, either sperm or egg provider for the pregnancy, carries what we call a structural rearrangement.
Can these all be done at the same time, or do they have, like, can you just do one test and do all of them, or do you have to do one test per type?
They're typically all mostly different tests. When we're doing PGT, you can typically order PGTA and PGTM on the same biopsy. And that's also true for PGT-SR.
Okay.
So typically you can do a couple of different tests on one biopsy to reduce the amount of times your embryo is being biopsied. Most clinics like to have the PGTM test made before a patient starts their IVF cycle.
And how would you make it?
Typically it can take around, probably industry standards, around 4 to 8 weeks to make a custom PGTM test. And usually that involves submitting additional DNA samples in your family.
Cool. So that's because you know that there's something potentially going to happen. Therefore, you create it in advance to then be able to test your embryos against that.
I think one of the challenges that many fertility clinics and providers face is how to really juggle all the different types of genetic testing that's available out there. I think fields are in tandem. So genetics is always growing, right? Genetics is always expanding. We're always learning more. The types of tests that we're going to be able to offer to clinics or to patients in the fertility clinic will really rely on genetic advancements in the field as well.
And are these hard and fast? I do the test, I get the result, and that's a guaranteed result.
Gosh, that's such a good question. So unfortunately, most PGT tests are screening tests in that they're very high detection rates and they're risk reducing, but they typically tend to not be 100%.
And then one final question for you. Do you ever see a day when you're not actually going to have to test the embryo itself, but you can test things around it to get to the same results?
Yeah, that's a good question. So I know there's a lot of research right now looking at something called cell-free DNA testing on embryos. What that means is looking at a type of test in which an embryo wouldn't have to be biopsied, but rather they're able to take cells from the culture medium and test those cells for PGTA or test those cells for aneuploidy. I think it would, offer a lot of benefits, right? It would reduce the wait time, reduce biopsies. You could maybe, depending on how fast that was, you could maybe do more fresh transfers, right? But we still have a little ways to go to understanding that test.
An ever-evolving situation, really.
Ever-evolving situation.
Brilliant. Thank you very much.
Thank you so much, Richard.